Good afternoon, everybody, and good morning to anybody who may be further to the west. It's a lovely afternoon here in Sweden, very sunny and crisp and cool, and I hope you're all having a good day wherever you may be. Very warm welcome to our third webinar in our series of webinars, excuse me, for our ECDC Community of Practice. My name is John Kinsman, and I work as a social scientist with ECDC, and I'm the project manager for this community of practice. Before we begin with what I think promises to be a really fascinating afternoon of discussion, very briefly, a little bit about what we are doing here with the community. We have a name for it now. Previously, in the first two webinars, we were just calling this the ECDC Prevention Community of Practice, but it is now called the Lighthouse. So it's the ECDC Lighthouse, and hopefully the image will be explaining itself. The Lighthouse is a community of people all over the EU coming together to learn from each other, to exchange good practices, and to be inspired by each other in the prevention of infectious diseases through use of a wide range of social and behavioral sciences. That's what we're here for. And the webinar series is one of the training elements, one of the streams that we have for giving colleagues all across the EU the opportunity to learn from experts in different parts of public health. And this afternoon, we have three really fantastic speakers who our Zach, our moderator for the day, will be introducing. And they're going to be talking about issues to do with building and maintaining public trust in public health, and especially the challenges to do with, for example, misinformation, polarization of discussions, and we're going to probably have a bit of a focus on vaccination. I think that'll be something that we're going to have quite a lot of discussion on. We're going to have the three speakers, and they will be making their presentations, and then there'll be discussions which Zachary Dessen, who's the moderator, will be facilitating. And Zach is a specialist in public health policy and research, working for the European Health Management Association. So with that, a very, very warm welcome. Thank you for joining us this afternoon. And I'm going to hand over to Zach to lead us through the afternoon. Zach, over to you.
A warm welcome from my side as well to everyone who's joining us so far. And I see a few people still trickling in, so welcome to those as well. I would just like to get a few housekeeping notes out of the way before we really get started and get our discussion going. So just a couple of things from our side is that I see some of you have your AI note-taking apps that have joined probably automatically. Those will actually be removed from the meeting because we will be recording this meeting, and the recording will be uploaded to the EVA platform and eventually onto the ECDC Lighthouse once it's launched. So just for your information, you'll have access to the entire conversation and the entire video there. So big point from my side, you've been really good over the last two sessions at generating important questions, really thought-provoking questions, and I encourage you to keep that roll going. And as you think of questions, please post them in the chat. They're highly encouraged. We're going to be asking them directly to our speakers and using them to help fuel our discussion. So please become a part of the discussion yourselves and post any questions you think of. And if you see a question you like, please put a like or a heart on other questions, so then we really get a sense of which ones are kind of burning to be answered. And essentially, that's more or less it from me. There'll be, as John mentioned, three good presentations from our experts we have with us today. And then we're going to have a bit of an open question and answer session to close the session. So with that said, it's my pleasure to introduce our first speaker today. It's Professor Maya Goldenberg. She's a professor of philosophy at the University of Guelph in Canada, where she researches and teaches on the philosophy of medicine, science and values, and public trust in science. She's the author of Vaccine Hesitancy, which was published in 2021, and she frequently engages with media on issues surrounding public trust, vaccination, and public resistance to science. So Maya, welcome, and the floor is yours.
Thank you so much. Thank you, everyone who's come here today. It's a pleasure to be here. It's also a pleasure to share my research with you and to join this excellent conversation. So this panel, of course, is about building and maintaining trust, and I think we're all coming at this issue from the perspective that scientific and health governance institutions like the ECDC could use more of it. So, of course, we ask, how do we build more trust in science, and why don't some members of the public trust experts even when the experts are trustworthy? So there's lots of research editorializing on this question, and the dominant thinking on the subject is that points to misinformation as the source of the problem. Misinformation, of course, can lead people of members of the public to doubt scientific claims, and public health advice might be questioned. And what I'm going to suggest today is that we should reverse that causal direction. And instead of saying that misinformation causes poor trust, instead, poor trust leads people to questionable sources and unorthodox views. In other words, I'm now getting to the concepts that are on the screen that I know need to be defined. In other words, what people believe depends heavily on who we believe. So the ECDC and other similar institutions should be asking, what does it take to be a trustworthy expert source, rather than asking, what's wrong with those people who don't trust the experts? So now let me define those terms. So starting with this idea that what you know depends heavily on who you trust, or who you believe to be a trustworthy source. That is the concept called epistemic trust. It's used quite widely in philosophy literature, epistemology. It's also made inroads into psychology and psychoanalysis. The idea here is that if you want to build and maintain public trust in science, that effort hinges on scientists and scientific institutions being recognized by the public as trustworthy. And failure to establish public trust in science is going to easily steer some members of the public towards unorthodox sources, questionable claims, and even conspiracy about those very institutions. So here are some characteristics of knowledge relationships involving experts and non-experts. And this kind of relationship that I'm describing can be between scientists and the public, but it can even be, let's say you're asking a friend for advice on a restaurant because they've got more expertise than you do on the local restaurant scene. We believe people who have the appropriate credentials. It may be a PhD, but it also might be a lived experience that makes them experts in this thing that we want to know. Also some knowledge that they do their work carefully. They check up on restaurant reviews and the like. We also believe people that have our interests at heart, and because of that, will report honestly, will give us true information instead of make something up. And that speaks to the moral character of the experts that we pursue and listen to. We also tend to believe those who understand our concerns and know where we're coming from. The term for that is empathetic understanding. So what does that have to do with trust in science? What does it mean to trust science? The popular thinking about science would have us say that there is no connection between trust and science. I'm reaching towards the folklore of modern or European Enlightenment science that draws on heroic figures like Copernicus and Galileo, who, of course, bravely eschewed the church dogma of the day and instead trained their unfettered eyes to the natural world and employed dispassionate reasoning in order to know the world. And that is a little bit of folklore. Science doesn't really work that way, but you've probably heard that story before. You might know that the Royal Society of London maintains the motto nullius in verba, which translates to on the word of no man. So in other words, the traditional story of science is that we don't trust, we just follow the evidence. And of course, that story has a certain appeal. That's why we keep telling it. But that model of rationality, which is grounded in the solitary thinker who only trusts beliefs that are verified by their own examination of the issue, doesn't really capture what science is like. The second image on your screen is a better account of science today. Science is a social enterprise where scientists are trusting all the time. They are building on previous research that they trust to be careful and true, even if only provisionally. They work in collaborative groups where they might divide the labor based on the project, based on the expertise of others. So what I'm just describing here is a very normal account of scientific knowledge where trust is running through and through, invisibly, but importantly. You're trusting the past literature, you're trusting colleagues. Now, that's within scientific communities. In everyday life, each of us, much like the scientists I described, also do a lot of trusting. We wouldn't know very much if we only relied on the beliefs that we had studied for ourselves. The world is too complex and there is too much to know. So people who want to know things are reasonable to rely on knowledge claims made by experts rather than trying to figure out everything for themselves. The term for that is epistemic trust. I'm going to give some definitions of it from the literature. To invest in epistemic trust in someone is to trust her in her capacity as a provider of information. That's said by Torsten Wilhelm, who's a philosopher of science. I mentioned it's made it into the psychology literature. Epistemic trust describes the willingness to accept new information from another person as trustworthy and generalizable. And this last quote, I wanted to put it up because it brings epistemic trust into scientific domains. The philosopher John Hardwick wrote, in most scientific disciplines, he means those who do not trust cannot know. Those who do not trust cannot have the best evidence for their belief. Okay, so with that definition in mind, let me step back a little bit and say what exactly we mean by trust. Trust, of course, I'm talking about trust in science mainly, but it's got some parallels to what we usually think about as interpersonal trust. There are some connections between the two. Okay, so there's a lot of literature on trust. You'll find it in ethics, philosophy of science, in social theory, and there's a general use of the term to mean having confidence in someone or something. Now, trust in the context of science can be about trusting your colleagues to store their chemicals properly, but most of the discussion is about epistemic trust when we talk about trust in science, to trust someone as a source of information. When we trust a person, and we can also trust organizations or institutions to be trustworthy, we are saying they are worthy of our confidence. And I just want to bring in a little bit from the moral philosopher Annette Beyer, who said that trust is more than just merely relying on a person. If I trust you, I exercise a kind of relying that makes me dependent on your goodwill. So by doing that, by making that claim, Beyer highlighted the vulnerability associated with trusting others. And the vulnerability ends up being important here for our task today. In science, that vulnerability is associated with trusting someone who makes knowledge claims that if we are misled, we might be hurt by it. So trusting others characteristically makes us vulnerable. That's why it gets a lot of ethics attention here. It makes us vulnerable, but it is absolutely unavoidable. We wouldn't get very far if we didn't trust others for knowledge and for help when we need it. So when we find ourselves in situations where we lack information to know for ourselves, we trust others, even though we know that trust might be broken. Trust has been described in the sociological literature as something akin to a leap of faith. At some point, I can do all my checks, but at some point, I just have to go for it. And that leap is this necessary bridging of an information gap. And that's true of all kinds of decisions that we make. At some point, we have to just trust the experts because our personal knowledge has only gotten us so far. So that's important when we think about things like why people vaccinate themselves or their children. It is not the data points or the proliferation of scientific studies that tend to convince people to vaccinate themselves or their children. Instead, it is that willingness to take that leap in favor of the scientific consensus. And vaccine hesitators and refusers are actually similar insofar as they also are faced with that leap and they may choose to decline it. So vaccine hesitators tend to situate themselves or live in different social spheres, whether online or in real life, in social spheres that tells them or instructs them to disqualify the majority view on vaccines. So what does trust do here? Trust is actually a means for social cohesion. That's why sociologists are very interested in trust. It creates channels of knowledge exchange, of learning, of friendship, and even solidarity. Trust creates social and epistemic networks. And nowadays we hear mainly bad things about epistemic networks. We call them epistemic bubbles. Online epistemic bubbles radicalize its members and sometimes leads them in dangerous directions. But it's worth thinking that trust networks of knowledge sharing can also be empowering, protective, and educational. It's a question about which epistemic networks you are drawn to. So against the claim that expertise is dead, how can expertise be dead if trust is eliminable? And that's usually couched in some kind of claim about our post-truth moment. I think that's another questionable claim. These skeptical communities are not anti-expertise. They have their own experts. The problem is their experts are not our experts. They might have scientists who profess some kind of minority view. It can also be celebrity influencers who seem to have no credentials at all, but they are recognized as experts nonetheless. So there's been lots of studies of public controversies over science, and there are some common findings. The first 2 points on my screen are probably the best known. You've probably heard this before. Factual claims, so throwing data points at you, does very little to settle debates. In fact, we have some evidence in the climate discussions that it actually makes things worse. Also, we are working against motivated reasoning that can push people to believe what our people believe instead of looking at the perhaps very strong scientific evidence. And that makes it, and because of that, it seems that they can't be compelled to change their minds. So of course, when you look at those first 2 points, that can be very discouraging. And I think this kind of despair that is probably felt by many public health scientists and workers, it invites a very negative framing of the public as the problem for public health. And I'd like to guard against that kind of thinking about the public. When you say things like, why didn't we get optimal coverage for the COVID vaccine? It's the public, of course. And because of that, the public needs to be fixed. They need information, they need myth busting or debunking, they need pre-bunking training. And if that doesn't solve the problem of the public and public health, we could just make vaccines mandatory, of course. That was a common line of thinking, because if you only look at points 1 and 2, what other recourse could there be? What I'm suggesting is a more charitable view. I'm recommending a more charitable view of the public as that they aren't somehow bad, but rather they are vulnerable to all kinds of bad choices about which experts to choose. The public, if we think about the public as epistemically dependent, therefore they are vulnerable to harm, and faced with this uncertainty, some will choose poorly. And of course, that's a more charitable view of what's going on here. And because of that, I think point number 3 on the screen here needs more attention. The attention to how it is that evidence for most of our belief relies on epistemic trust. If trust building is our objective, then we should not be scolding the public as if they are bad children. Instead, we need to bring in the public by increasing public confidence, increasing their trust in expert sources. So what makes the public trustworthy? I've already mentioned that confidence in expert advice hinges on what looks like an expert's moral character, not just their epistemic credentials. And there's research showing that this is actually what the public does when they are looking, who should I listen to? Who should I get information for? The public are usually not in a position of expertise that they can judge the information for itself. So they do what's called a second order assessment, where they judge the character of the source, of the person who's offering themselves as expert advice. They're looking for some signs that they are epistemically knowledgeable. That doesn't need to be a PhD or an MD, but they need to somehow show that they know what they're talking about. So we call that a good epistemic character, but we're also looking for good moral character. So our question for us is, what can experts who want to be trusted do in order to make the public assessment of their character positive? So I'm going to suggest I have three recommendations how to build and maintain trust for our purposes, which is infectious disease prevention. My first recommendation is don't subscribe to the war on science framework. Do not, as tempting as it is, subscribe to this polarizing narrative that it's somehow us versus them. Public health versus the public waging a war on science. There's, of course, a lot at stake in public resistance to science, our health, our democracies, our futures, but we need to try not to look at them as an enemy. That is never going to build trust. Public controversies are often framed as this kind of battle, of a war of science, battle over evidence, reason, with us on the side of evidence and reason and expertise and information, and those publics as somehow situated on the other side with nonsense, ignorance, non-expertise, and of course misinformation characterizing the people we are trying to reach. And you want to reject a war on science framework. I think there's reasons to think that the war on science framework is actually wrong, but I'm not going to go into that. I'm instead going to say it's not helpful if you want to build trust, to have this kind of us versus them thinking about the publics you're trying to reach, thinking about them as the problem and ourselves as the solution. Also, wars don't build trust and cohesion. They end in victors and vanquish. So it's not setting us up for building trust. I have two more recommendations, and I will stop after this, is the experts and the expert institutions need to do the work to show themselves and their institutions to be trustworthy. That might involve listening to the complaints of the public. You don't need to agree with them, but what would you do to show yourselves more obviously trustworthy? It might actually involve changing some of our practices. That could mean more transparency, more honesty, more engagement with the public. Those are the kinds of things that tend to build trust. I also recommend empathetic understanding in order to build bridges. Empathetic understanding is understanding where people are coming from. Try to understand why the public resists the kind of things that you think are so obviously that so obviously shouldn't be resisted. It's a change of thinking where you see where they're coming from and make and then make the expert institutions more responsive and more understanding of their needs. It doesn't mean you need to believe them. It just means you want to understand where they're coming from. Okay, I will stop there. That is how I recommend building and maintaining public trust.
Thank you very much, Maya, for that presentation. And actually, throughout the whole thing, I was kind of using this metaphor of, I'm remembering back to the pandemic, we had the medical officers and the politicians standing in front of podiums trying to explain to us why they were doing certain things and what the epidemiological situations were. And it made me think they really only have 5 or 10 minutes to build this trust or to show us that there's someone who is worth trusting. And I'm thinking on the other side, you have people who have a lot more time than that. They're not really busy with policy making, not really busy with coming up with the science themselves. They have time for some of the other side of building trust, such as community building, finding a bit more understanding of exactly what their audience is looking for. So I suppose my question is, I wonder what you think of that concept. First, that our officials, our scientists, our politicians, they don't really necessarily have the necessary training or experience in communication, and they're competing against people who really do and have a bit more time to dedicate to it.
Look, we have examples of public health officers and even politicians who did very well during COVID as well. And it was usually because the public found them relatable and easy to interact with. I'm thinking of a few public health officers, provincial public health officers in Ontario. So I don't think this crowd would know them, but they somehow came across as not just informative, but also caring. I will say it was notable that women were largely more successful than men. They were able to sort of be, I don't know, a little more caring, I'll say this. In terms of international knowledge, the Prime Minister of New Zealand at the time was kind of held up as a case. She would, Jacinda Ardern, I think is Ardern, I'm sorry, I think I'm mixing up her name a little bit, would do these fireside chats. She'd usually be wearing, casual clothes, and she'd talk a little bit about how hard it is to be home with kids. So it made her relatable, and it made her someone that they could trust. So it might involve taking off the suit and tie and trying to find ways to communicate with the public that are more relatable. But my point was only there are examples of even in the 5 and 10 minute cases where people were able to engage with the public. If our politicians need more communications training, they should get more communications training.
Then perhaps that's a good segue into our next speaker, actually, because we have with us also Professor Philipp Schmid. He's an assistant professor of health communication at Radboud University in the Netherlands. He investigates the impact of misinformation and science denialism on health decision-making, and he evaluates promising communication interventions that can facilitate informed decision-making. So welcome, Philipp, and I'll give you the floor.
Thank you so much, and it's an absolute pleasure to talk here. Welcome, everyone, to my talk on psychological interventions to counter misinformation and relate them to trust and build trust. I hope the slide set can be seen by everyone.
They appear just fine.
Okay, perfect. So we already set the stage with the prior speaker, and that is great because then I don't have to dive too much into definitions of trust. If we look at the last European Commission publication that I'm happy also contributed to on trustworthy public communication, and when we talk about trust, it usually has two dimensions. The one is that the person we trust should be motivated to act in a way that is worthy of trust, and it has a moral component that was already mentioned. We hope that the person or the person that we consider trustworthy has good intentions, is also open to our own personal views. And the second level is that that person also signals some sort of competence. So I will focus in this talk mainly on these two dimensions, that we feel respected by the other person and we believe that they have good intentions, but also that we think that person is very competent. Now, on the first thing, there aren't always players that have good intentions. And we heard from the first talk that it is very relevant to consider that the public, and when we talk to the public, that there are vulnerable groups to what we call disinformation. And there has been a lot of research on inoculation theory lately to try to protect people from disinformation by signaling that the sender of disinformation is actually not there with good intentions. So what we can do is we can also not only build our own trust, but also talk about the trustworthiness of other sources, and why the framing on war on science may be misleading if we think about the public as the enemy. A war on science from some specific institutions and also industries is, of course, in some battlefields happening. We just can think about the tobacco industry spreading disinformation and trying to make people, the public and vulnerable groups, smoke more. And if we inform people about that using inoculation by warning them about the fact that this is happening and giving them good counter arguments, we can show that they then try to think of that source as not a trustworthy source anymore. And there are, of course, other ways to do that, not only proactively inoculating people, but also debunking or reactively rebutting misinformation. In public discussions, we call that usually rebuttal, and it is about uncovering either the techniques that the person is using to mislead the public, or overwhelming the position of the other person by presenting your own evidence. For example, if a science denier would spread a message like this, where the main message is the lack of safety is an important issue of a specific vaccine, and that person concludes with the idea you cannot expect any fellow citizen to vaccinate as long as the vaccine is not 100% safe, then in this message we see that there are two things combined: a rhetorical technique that misleads, which is impossible expectation because no product is ever 100% safe, and the topic of safety. Now, how can we respond to those misleading messages? We described that in a World Health Organization, a guideline on how to respond to vocal vaccine deniers, but we also tested this, of course, empirically, and the idea is the following. You can focus on the specific technique, uncover that the message the other person was spreading is not a competent one by uncovering how misleading the rhetorical techniques are, mentioning that no product is ever considered 100% safe and that this is an impossible expectation. We can also overwhelm the topic of safety by presenting all the evidence we have on that case. Does that work? Does technique rebuttal, unmasking work? Does topic rebuttal work? We looked in several experiments on whether it protects people when they're exposed to misinformation on their change in intention to get vaccinated. We asked them about whether they want to get vaccinated first. Then we presented a public debate, either with only a denier spreading false information, topic rebuttal being present, technique rebuttal being present, or a combination. What we see in the data is that, yes, people are influenced by this kind of misinformation. Their intention to get vaccinated decreases, but this drop isn't so heavy if you rebut misinformation by presenting evidence with good reasons, by uncovering techniques, or by a combination of both strategies. Now, the combination is much more complex than only using one of these techniques, but has no real empirical benefit here. So you can use the knowledge you have to counter misinformation if you know a lot about the issue. You can also uncover rhetorical techniques. If, for example, you're a journalist or trained in uncovering techniques, then that also works. Now, what does this have to do with trust? In this specific series of studies, we did not look at trust specific as an outcome, but colleagues did when we counter misinformation and we explain why the misinformation is wrong. That increases trust in the countermeasures compared to just labeling something as wrong or false. Now, it's not only good explanations that work. In another set of experiments, we looked at the style of how we present explanations and why while aggressive language did not change anything about the persuasive impact, it did change a lot about the perceived competence of speakers. What we see here are very large effect sizes of perceptions of competence, the subcategory of trust, if you use aggressive language in public discussions, countering other people. So empathy, and we heard that in the first talk, can be, on the other hand, a good measure to increase the impact of your countermeasure against misinformation. Now, this is all mass communication, and I just want to say something about personal communication, because there the aspect of empathy plays an even bigger role. I don't want another vaccine, it'll overload my immune system, could be countered in theory with a blunt statement of vaccines are safe and effective. Get over it, basically. But that would completely ignore the question at hand of the person who is vaccine hesitant. That person asks, is this person competent? Does this person care about me? What are the intentions of the person? Is he or she open to my concerns, measures, or dimensions of trust? Now, we looked at a specific new interview style that addresses that based on so-called attitude roots. Everything a patient or a person can say is basically infinite because there is an infinite number of statements you could be faced with. But these statements usually can be categorized in what we call attitude roots, underlying attitudes that drive these leaves of statements. If we cut a leaf, it will just grow back. If we address the attitude root with empathy, we can actually tackle the misinformation and build trust. That is the key idea, and we follow an interview style that is also very much related to motivational interviewing by first trying to elicit the concerns of the other person by asking open questions. What do you think about vaccination, rather than vaccination is right? By affirming the worldviews and concerns of the other person, by offering a tailored refutation, and then at the end providing information. We looked at that in an experiment, and this is very much my last point here, by comparing several conditions. First of all, the control condition, where we have this blunt statement of vaccines are safe and effective, a refutation of the misinformation, just like rebuttal, and a response that is built on empathy, that starts with, it's normal to have questions and doubts, respecting the worldview of the other person about medical treatments and wonder how our bodies will react. We definitely don't want to overuse any type of medicine, and then start to rebut. This extra affirmation, this empathy aspect, does it change anything about how competent we think the other person is, and also how trustworthy? Well, in the data, we see that if you add a refutation, well, the competence in that person doesn't increase that much. But if you add the positive empathy aspect to it, it does increase. The same is true of how compelling do I think the doctor is, and we also measure trust, and there we see the same pattern. So adding empathy in personal conversations is key to counter misinformation if we actually want to change something. We have all these things and all these specific interventions at hand, and they address specific and different aspects of mass communication, personal communication, and also whether we decrease trust in sources that are not trustworthy or build our own trust. But in the end, they are not all like key solutions or single solutions to a big problem. We need to combine them as a sort of overall strategy, and that costs time, unfortunately, as it always does when we talk about building trust. Thank you.
Thank you very much, Philipp. And I really appreciate that you brought some of this research that I've never seen before, and I think might be new for some of our audience. And I might get us started actually with something that jumped out at me right away, is when you looked at the idea, the impact of a vaccine denier coming into a forum or a public setting and delivering their misinformation, that even with a combination of topic and technique rebuttal, it's still not enough to fully counteract the negative impact. I wonder if you have some thoughts as to why that is.
Yes, we actually do see that a lot in vaccination debates, and that is also probably because a lot of people start off with very, very positive attitudes towards vaccination. The public and a lot of public questionnaires show that are often very much in favor of it. So increasing that even further is often not possible because they already are at the end of being very positive. In other debates, we see that with a combination or also with single strategies, we can even increase the intention to do several things like pro-environmental stuff, but also using gender-neutral language.
Thank you. And Maya, I'd actually like you to jump in on that idea, because this concept that negative information sometimes seems to have a more disproportionate impact than positive information, I think also comes back to who we trust and why. So I wonder if you have some additional thoughts.
My additional thoughts about negative information actually is informed by a lot of media studies scholarship that pays attention to how people consume information, presumably media and information, all kinds of media. And the emphasis is usually that people are lazy when they read the news. All of us are. And because of that, we don't remember much. So things like if you highlight the negative account, that might be what people remember, and they may not remember the lengthier rebuttal of let's say some misinformation. So there's been some suggestions that you don't want to repeat negative claims, by which I guess I thought we were talking about misinformation, but I'm not sure if that's what you meant, and instead try to call attention to the positive account.
And I think that's a really good point, because I mean, that's how they sell newspapers in the end, is negative information up front, and tends to be what we remember. So I think that's worth considering as well. And Philipp, I'm going to come back to you with a question from the audience. You mentioned at one point about training public spokespeople, to both appear more competent and to appear to have more empathy. But really the question is, how can you train someone to appear more empathetic, or really actually genuinely be more empathetic, and ensure that you kind of build in them this moral character? Is there a training method that you noticed have worked, or is it a real challenge?
Yes, I mean, of course, it's always a challenge to train people, especially experts who have been in the field for a long time, changing their style of engagement. But a lot of the people and also medical doctors are doing that intuitively if they work a lot with patients. But this empathetic refutational interview that we designed, we actually also now train this to doctors and also measure in the field how well this actually works. And the idea is to first understand these attitude roots. We have a website, I can put it in the chat, it's jitsuvax.info, where we present all the different attitude roots and also present the empathetic refutations for over 60 misinformations about vaccination, and what you can say on a word-to-word base. And if you understand the attitude roots first and then learn to address them by affirming the underlying kernel of truth that everyone spreads when they talk to you, that can actually help. It's the same with motivational interviewing. You can learn to identify attitude roots and also be more empathetic by affirming beliefs of another person. So that's learnable.
And actually, that brings me to perhaps bring in our final speaker one moment ahead of time. So Adam, I'm going to come to you just before you give your presentation. And I wonder if you can even talk a little bit further about what Philipp was saying, and how, I mean, I know you've worked with people who are really out there in the field trying to get messages across. And I'm sure there are differences in how they come across to people, their ability to communicate, and their ability to, let's say, naturally build trust in those that they're talking to. Did you have some sort of training programs that really focused on this level of communication?
We don't have anything that we've formally produced, but I think that, and I think maybe what will come to the fore in my presentation, is that having built kind of a community of practice over the last number of years, being able to share kind of lived experience and understanding of communities that are affected, say, by STIs, and how we engage with sex or seek pleasure, and understanding then how we interact with our health services, being able to, I guess, bat back and forward the lived experiences and how those things interact has allowed for us to be able to understand the best ways to communicate with one another. So I think, while we haven't produced something academic or structured, I think through the community of practice, that's something that we've developed.
Thank you. And that actually leads me well into another question from Catherine in the audience. And I'll come back to you, Philipp, because Catherine asks if there's a gender difference between how one can or cannot gain trust. And I know, Maya, you touched on this with your intervention a little bit earlier. But I can imagine also that comes to ideas of ethnic origin or cultural background. And if you found in your research that people delivering rebuttals or people delivering this empathetic interview are more well received or build more trust if they come from similar backgrounds or have a specific profile.
That's actually a good question that we are looking into right now, especially the idea of cultural background and gender, but I don't have specific data yet on whether that increases even that level. I would hypothesize yes, because it is way easier to build that sort of relationship fast if you already signal that there is some sort of common ground to the other person, and that makes it easier to build trust. But I don't have specific data on that yet.
case, we'll look forward to it. And I think based on the discussion so far, it might be something that we end up coming back to after our final presentation, which takes me to Adam, actually, in the official capacity. So Adam is our final speaker today. Welcome, Adam. He works for MPOWER as a program manager. And MPOWER is a peer-driven program addressing the sexual health needs of gay and bisexual men in Ireland. With years of community experience, he creates innovative, people-centered interventions that prioritize trust, cultural sensitivity, and equitable care. Adam bridges public health policies and community needs and advocates for inclusive, accessible health interventions. So Adam, welcome, and the floor is yours.
Thank you, Zach. You can hear and see the slides okay?
Yeah, you're good to go.
Perfect. So yeah, thank you, Zach, and fellow speakers and ECDC as well for inviting me to come and speak to you at today's webinar. I'm doing so, I suppose, not as an academic or a clinician, but as an advocate for community, a community disproportionately affected by STIs. So as a gay man working at the intersection of community and health. And for that work to be effective, I believe that trust is foundational. I think that when communities have trust in our healthcare institutions, we're a lot more likely to engage in health-seeking behaviours like prevention and testing and treatment. But trust also works both ways. Communities are the experts of their own lives, and what might seem, like a logical approach on paper might not fly when introduced to an affected community. So that's why I believe a community of practice approach to public health is the most productive approach. And I think for that to be fruitful, trust must be at the center. So with the time that I have, I wanted to introduce you to MPOWER, using it as a kind of a case study for community-based trust, and to demonstrate how the 2022 MPOX outbreak was a test of that trust. So I created the MPOWER program as I kind of recognized the need for a kind of a community-led response to the sexual health and well-being needs of gay and bisexual men. I built a fantastic a team of like very passionate and empathetic guys who wanted to support our community in having a healthy and pleasurable sex life. So this is the team on the left, and on the right is just a selection of some of our volunteers. We're 50 peer volunteers strong, and while we had big ideas, we were kind of starting from scratch, and we needed to build recognition and trust within our community first, and also within the sexual health sector also. So we set to building that trust by taking time to listen and to understand the challenges experienced by members of our community. We created peer-led rapid HIV testing in gay bars and gay clubs on evenings and weekends to remove barriers experienced in accessing testing. We utilised hookup app and dating sites as spaces for us to offer information and support to those that might not be out to their healthcare providers. And we were visible and vocal about the need for the introduction of HIV PrEP. So we kind of built recognition, rapport, and in time trust. And these pictures are taken at different points over the past 8 years, meeting with sexual health clinicians, leaders in public health, our health service funding partners, and also government figures. And at first, I guess these were just kind of brief meetings, but over time, we collaborated on campaigns and initiatives, getting to know each other and supporting each other in our shared goals, and again, with the aim of building trust. So an outbreak of Shigella linked to a sex on premises venue in Dublin was a first kind of test of trust. Public health teams kind of wanted to close the venue and kind of seeing it as a source of infection. But with relationships built, we were able to kind of describe how the venue should be seen as a place of intervention instead, where we can raise awareness with the venue owner and the service users. So essentially closing the venue disperses these people, making it harder for us to engage with them in health-seeking behaviours. And this worked. And I think, trust, again, was both demonstrated and built both ways. In 2020, in the summer of 21, a national outbreak of syphilis was declared. And this happened just when the health service was limited due to the ongoing response to the COVID crisis, which meant that testing and treatment opportunities were greatly reduced, was when they were needed, the most. So in collaboration, again, with health service colleagues, we created a syphilis testing pop-up and awareness campaign that engaged hundreds of gay and bisexual men across Dublin who may have otherwise, gone untested. And all this is to say that, again, trust building has taken time, and lessons carried from past outbreaks underscored the importance of, transparent communication, cultural competency in response, and swift action to kind of foster and maintain community trust. So then in the summer of 2022, a public health emergency affecting our international community arrived, which is MPOX. And before the first cases were identified in Ireland, a national crisis management team was convened by the National Health Service. And I and a colleague from another community-based organisation were asked to represent our community as members of the team. And so from the beginning, we were, and by extension, our community, were being meaningfully engaged in the response. And given the very specific kind of targeted impact of the virus on communities of gay and bisexual men, the agreed strategy was to facilitate our community organisations to lead the communication and community engagement efforts in collaboration with colleagues in our National Health Service. We created a 3-stage campaign: alert, empower, and mobilise. And we were alerting the community to symptoms, transmission routes, testing opportunities. We were empowering folks to make informed choices about their sex and their social lives during the outbreak, and then mobilising the community to get vaccinated when vaccines were made available. Importantly, we were also at the table for clinical decisions, testing infrastructure decisions, vaccine planning, epi updates, and so on. And as I said, I'm not a medic or an epidemiologist, but I was treated as an equal stakeholder, and being at the table allowed for all of the decisions that were being made to be community informed. And so trust built from the years of developing a community practice allowed for authentic shared decision making, and I think authenticity is a real cornerstone of building trust. Sorry for all of the jumping around of the slides, but I think there's actually a timer on my slides for some reason, so apologies for that. So then, yeah, while on the whole, the response for the community of GBMSM in Ireland for this collaborative effort was well received, there were points when trust was shaky. The rollout of the vaccination programme faced significant challenges due to a worldwide vaccine shortage. As a globally connected community, Irish gay and bi men could see via social media that their peers in the UK, in France, the US, Canada, they were all getting vaccinated in June and July, where in Ireland, the initial phase of the vaccine rollout took place in August and was limited to 600 people deemed at highest risk of acquiring MPOX at that time. And wider rollout didn't commence until mid-October for all those who self-identified at risk of acquiring MPOX. So although this was due to shortages in the availability of vaccines, slow and limited access was perceived by many in our community as a lack of urgency towards a minority community. And this sentiment was kind of felt most strongly when compared to the kind of swift and comprehensive vaccination programme that was stood up in Ireland for COVID in just the year previous. So while for some in the community, this may have broken their trust in the efforts to respond to the Mpox outbreak, we felt that the best tool at our disposal to restore trust was in transparency about the process. So we did this through frequent website updates and social media posts. But one of the most important efforts of transparency, I think, was holding space for community and decision makers to meet. So here's a picture of one of the number of town hall talks that we took, which was essentially an online space where community could hear directly from decision makers about the processes underway and the reasoning behind the decisions that were being made. And it also allowed decision makers to hear from community about our frustrations and our needs and our fears. So while this was all happening during the height of the outbreak and just before vaccines were available, we commissioned research on the community's perception of the response to Mpox. A section of that research related to how informed people felt, how trustworthy the information was, and who they trusted the most. And generally, respondents felt well informed and believed that they understood public health guidance reasonably well. Almost 2/3 of participants relied on community-led organisations to stay informed about the outbreak. Irish community-led organisations for GBMSM were rated as extremely trustworthy, followed very closely by healthcare professionals in sexual health clinics, and then Irish government sources, so the Health Service and the Department of Health. So while it was a deliberate and intentional move to allow the community organisations to lead the communication and engagement efforts, and at every turn it was highlighted that the efforts were in collaboration with the Health Service, it was sometimes perceived that community was acting while statutory health services were not. And for some respondents, this perceived lack of urgency in the management of Mpox was related to a feeling of a lack of care for the community by the state and its agencies. So despite the positive outcomes of the affected community being well informed, getting their information from trusted sources, and acting on calls to action, it seems that trust is hard earned but is easily lost. And so for that reason, I also think reflection is really important. I don't believe that communities go out of their way to distrust establishments. If anything, I think, all of us, people want to feel part of and feel valued. So I think if distrust exists, then I think the work starts in understanding people's experiences and why we've gotten to this level of distrust. So drawing to a close, I think when asked what we need to build trust in communities from a community perspective, I'd suggest it consists of time. Take the time to get to know, work with and understand your communities. Authenticity, I think meaningfully engaging communities early on. And I'm reminded here of that kind of mantra of nothing about us without us. Transparency as well. I think being honest and upfront about what we know, what we don't know, makes it easier to trust what's said when we do. And reflection. I think people's sense of trust comes from their experiences. So hear them, understand them, and I think we can work to improve trust. So finally, I just want to give recognition and praise to those involved. It takes a village. This was our community of practice. And I'm very thankful to all of them and to all of you for listening. So I'll leave it there.
Thank you very much, Adam. And I think that's a really excellent showcase of the practical side of things. I know when we talk about the science and we talk about the philosophy, it's really also important to see some of the work that's being done on the ground in trying to build trust, some of the real practical challenges that you face. And I really like the way you put it, nothing about us without us. It sounds like when we got to the stage of the Mpox outbreak, you were at that place where you really felt that your community was listened to, that it was actively engaged. But I'd like to maybe rewind the clock for you back to, I think you said 8 years ago, you really started working on this. And what kind of practical first steps you took? Was there already a baseline of trust to build on, or did you start from nothing? And what were the first steps you took to start building this trust, which obviously you've been working on and took you quite some time to establish?
Yeah, it wasn't there, I would say. I think, I've worked in the community prior to, starting the MPOWER program, but in terms of sexual health, we were kind of the new kids on the block. And of course, we have a great legacy within our community of support, particularly around HIV, but also STIs that have been handed down and from our elders. But I guess, as I say, we were kind of the new kids on the block. And one of the first pieces of work that we delivered was a peer-led rapid HIV testing program. So we were training gay and bisexual men to offer HIV tests in our community spaces. And when we started that, gay men were kind of horrified, actually. When we were starting testing in these venues, people, when we kind of started to promote that this is what we were doing, our community was like, this, I mean, is someone going to walk up to me in a bar and give me this really important health information, while Kylie is blaring on the speakers. So it took us, we had to build that understanding that, we're doing this to remove barriers to many of the barriers that we experience ourselves. We are a community that are experiencing some of the same concerns that you have around HIV or HIV testing. And I think slowly we were able to kind of impart that we've given this a lot of thought, and that when people started to use the service and realize that it was very well thought out and very comprehensive, and that the support structures and referral pathways were all sound, that those good experiences were shared within the community, and then that kind of snowballed. And then, as I said in that presentation, when we then started into other kind of outreach online and in venues, but then also when there were outbreaks, smaller outbreaks, more contained outbreaks in kind of subpopulations within our community, there was an understanding that we kind of had a history in this, that we have the community in mind. And I think it has been a gradual increase since then. MPOX was the biggest test of that. And I do think as we've come out the other side and we're looking towards other interventions for our community, we're often a first port of call for our community. And I think that would be maybe demonstrating that trust is being built on.
Right. And I think actually it really gives a good kind of summary in the arc of where you started and where you came to, but also the idea that trust, it still has a bit of fragility to it, because obviously, as you mentioned, when there wasn't enough vaccines available, people could see they're connected. They see that, oh, my friends in Canada or the US are getting these, and why aren't we? So I wonder, when you mentioned, I'm sure it was a bit of a painful and frustrating experience for you, but was it that trust was lost in the entire system that you'd created, or did you really find that maybe your organization was still trusted, whereas maybe then trust in the government or the health institutions was lowered?
Yeah, I think that there's probably two parts to that, right? Because I think that there's long-standing experiences of minority communities and authorities, even if that is a health institution, and understanding how those communities engage with those institutions, I think, is really important. What is the base level of trust, and where are we starting from? But I think when we were maybe behind quite a bit in terms of the rollout of the vaccine, I think trust was damaged but not undermined. And I think what was really important, and the example that I gave of those kind of town hall talks, was being as transparent and upfront as possible with I think for the normal Joe Soap, gay on the street that was really wanting to get their vaccine, European Union vaccine, HERA, all this kind of, agreements and policy is not to the front of their mind. And so being able to kind of bridge that gap and that information, being transparent that as to why vaccines were short-coming kind of helped. But I do think ultimately we have been able to bring that trust back. When vaccines were made available, people rolled up their sleeves in their droves, and I think as Ireland had one of the higher rates of vaccination for mpox among our communities. So I think, you know, when the call up to action is there, the trust is, I think, helped that people came back to the table.
Fantastic. And I mean, I'm happy to hear as well that you feel that, you know, even despite some bumps in the road, it's still a positive trajectory, and the work you're doing really kind of can continue if it's done in the right way. And I'm going to throw to you one more question. It's going to be a combination of a few questions from the audience that I think will then help us open back up the discussion with our other two speakers. And that is if there are cultural differences in terms of trust. So for me, that means, you know, people obviously from different ethnic or religious backgrounds might understand who they trust and what trust means to them is different. But from your perspective, I'm curious, because I imagine most of your work is done in Dublin and fairly urban settings. I wonder, as you work between different communities across Ireland, some more rural, some with different, even within Ireland, of course, cultural differences. I wonder what your approach is to reaching some of these different communities and different types of people.
Yeah, it's a really good question, and I think it's really, really important. It is something that we were acutely aware of in all of our work, really, is not to leave anybody behind, right? And I think, you know, everything that we produce from MPOWER is produced in a number of different languages. Obviously, English is our predominant language, but we have a really vibrant Latin American community in Ireland, and so what we produce is also in Spanish and Portuguese. In relation to the mpox vaccination program, unfortunately, it wasn't something that we were able to stand up in the end, as these things happen. But we were listening into our communities, and we were recognizing that there were a number of really large events that gay and bisexual Latin American men attended. We saw that that there was a much lower uptake of vaccine among Latin American gay men in Ireland for the mpox vaccine. But we did know where we would be able to engage those men, and we tried to have vaccine pop-ups in those spaces. Unfortunately, as I say, it didn't come to pass. But I suppose the point there being is that we recognized and we attempted to include. I think language is really important, but so is and that kind of cultural aspect of understanding how people engage with health, and, you know, the right time and the right place. But also your point on, you know, Ireland is kind of heavily weighted to an urban setting, and I think, as is the case, I think for a lot of queer people globally, you know, people tend to move towards big urban centers. But of course, you know, LGBT people live in every corner of every country, and so we've, I think, through our outreach work and engagement with local, regional community organizations that work with LGBT people, but also I think harnessing the unique opportunity to use hookup apps, that's a really easy way of getting information directly to our communities, particularly those that are at risk, seeking sex through those hookup apps. While the critical mass of people are weighted in the kind of urban areas, we did at those meetings when the vaccine program was being kind of developed, consistently highlighted the importance of having rural vaccination points throughout the country. And so I think that to a certain degree was also successful. So I think, you know, that mantra that I had said about nothing, you know, about us without us, that trickles down to every single kind of component of a program for it to be successful, because it can be, you know, sometimes not intentional, but possible to leave people behind. And I think when those people are at the table, it's harder to ignore that.
brings us to Maya, because working in Canada, obviously with also a strong tradition of multiculturalism, a federal system of government where the provinces are the ones who manage the healthcare system delivery. I wonder if you've seen, I mean, I don't want to say a universal concept of what trust means to people across cultures, but is there something even close to that in the ways that we can include in our messaging? What things reach people in general? Or are there really big differences between cultures that we need to give them two separate messages?
If I wanted to make generalizations, I would say trust is usually at the local level. So I agree with many things that Adam had to say. So creating relationships are usually done at the local level, and it can grow from there. So I'm going to use examples from COVID vaccine outreach across Canada. It's a big country. It is done at the provincial level, but there's many different communities with very different relationships with healthcare and also different needs. So there was quite an effort early on in the vaccination process to offer, vaccination rollout, to offer very culturally specific town hall meetings to communities, especially communities that have historically have skeptical relationships with government and with healthcare institutions. So they would usually be language appropriate. The speakers would often be members of that community. They could either be healthcare providers and scientists come from that community, or they might be community activists and people that are known and trusted. So that demonstrated that hearing from your people, they use the language of local ambassadors at some point, speaking with people that share your history, that know at least in general where you're coming from, goes a long way. I was able to attend some of those town halls, often not as a member of that community, but just as a participant who disclosed why I was attending them. And they would often give health advice that was quite similar to what you would get on a Health Canada website. That's our national health institute. But coming from somebody that knows your history and knows where you're coming from offers a certain connection that wouldn't be there otherwise. They were also able to provide context. Like sometimes the language would be couched in, we know we have a history with the healthcare system. Our community has struggled, and it would say something like, but these vaccines are something that we can rely on as a way to keep ourselves safe.
That you mentioned this idea of the National Health Authority kind of having one central message and that being diluted or not necessarily diluted, but spread through different voices, let's say, across different categories. And Philipp, I'm wondering if you have to give one person at the top of an institution the responsibility for crafting this message, this is the one that's kind of central to all of the other health messages that get out there. How would you go about measuring, and maybe this is part of the work that you're going to be doing. I know you mentioned you're going to be looking into this kind of thing, but how would you go about considering the factors that need to go into that message so you reach the broadest possible audience, that you build trust with the broadest possible audience? I can imagine some of these town halls that Maya mentioned, maybe you can measure some aspects of different speakers there, or maybe there's another methodology you had in mind, but I'm curious about your thoughts.
Yeah, I think we have to be honest about what we can actually reach with, for example, a very top-down message when it comes to trust. I think this was also mentioned by the previous speakers. And what we can do with that is basically signal at least some sort of competence and trying to give people some sort of relevant information that is highly relevant in the decision-making situation that the individual is in. When it comes to really building trust, we also mentioned, all three of us, the aspect of time. Then we need to go to really to the local situations where we talk eye to eye, where we have peer-to-peer conversations. And in these conversations, the benefit of that is that the entire idea of psychological or communication scientific tailoring, of really tailoring your message to what the other person is saying, works very well. doing that on the more global level from a top-down perspective is very, very difficult because you don't even know who's listening. So how can you then tailor? It becomes very tough. So you can only deliver some sort of very general message. And what you need to do to design that type of a message is you need to have data. And one of the problems of also that we faced during COVID is that a lot of these public perceptions of who is the person who should spread the message? What should a message contain that signals some sort of relief of, okay, now I will go and get vaccinated? What are the actual reasons of vaccine hesitancy? Because these need to be known to then specify your message. And a lot of these data collections were started during the COVID pandemic as grassroots actions from academia, basically. And then slowly, countries and also in bigger institutions also started to collect this data. And to be fair, this was way too late to then design sort of inoculation interventions and all that. So what we need is we need data collections and also pools of data now, because the next pandemic, for example, is just a matter of time. We know this. So we need to start collecting this data, who is relevant, what kind of content is relevant to the people. And then we can also be more specific about what is the top-down message that works.
Thank you, because you've set up actually another question from the audience perfectly. And this one's for Maya, and it's a bit difficult, I will admit, I think, because Ola is asking, what are some concrete changes that health organizations can implement in their daily operations to demonstrate trustworthiness to the communities? I mean, it builds quite a bit on what Adam shared, and obviously what Philipp has just shared about the idea of needing the data to really know how to take those first steps. But I'm wondering if you have some ideas or have come up with some thoughts maybe around that.
More interactions with the community is a great way of building trust. It's usually done at the local level, but I'd say more activities with communities instead of just hearing from something like your provincial health unit when there's an outbreak. That's not a great time to start building trust, and you certainly shouldn't expect to have it. So there's all kinds of interactions that can be done during calm times and healthy times too. Adam's group is a great example of that they've got sustained and continuous relationships in the community. Other things that could be done is I'd like to address that there is significant public distrust around industry-funded biomedical research. And of course, the biggest way to help that would be to create more arm's length or more regulation around industry influence on research. I don't see that happening in the near future. I think there's good reason to do it, but that's probably not going to happen. But there needs to be more attention to the things that people are concerned about. And I mentioned that one because it is such a big concern. It comes up in all the interviews around vaccine hesitant parents, COVID skeptical people for themselves or for their children. And it seems like the large institutions just want to push that away and usually don't comment on it at all. And I think there is more attention that could be given to it. It might change, it might create regulatory change. Another one is addressing community, other sources of distrust, which a big one is mistrust of health institutions by marginalized communities. More could be done around that. And this one is actually easier to do than, cut all industry funding or create more checks. And that is more representation of community members within these institutions, recruiting and retaining faculty at university, students from communities that are typically underrepresented by these institutions goes a long way to making change.
Completely agree. And actually, it makes me think, because we've talked about trust from the local level and the community level, and trust really at the highest level. So we're talking institutional messaging. And Philipp, I wonder if we can kind of go somewhere in the middle, because it's clear that healthcare providers and the health workforce are some of our most trusted individuals and trusted voices when it comes to especially things around vaccines and prevention. So let's take the example of a GP working in a family practice. And you have this concept of training them for a bit more empathy, but I think a couple of questions from the audience are fair ones. There's one that says, clinicians don't often have the time to participate in this training, nor do they have the time necessarily to, it takes time to listen properly and to give a proper empathetic response. So what are some of if we're going to just really nail down some of the most important aspects of a really quick training program, like, let's talk about it in a practical sense. How can we train busy providers in the best possible way?
Yeah, I think, of course, we can offer, and we actually do that, like three-day trainings for people that give them the ideas of how we can produce more empathetic interactions with people. But of course, there is always this element of time. Who can actually do that? And also, within the infrastructure that we have now for medical doctors, isn't that also a lot to ask of one single person who will be busy during a crisis vaccinating to also then sometimes like attend several workshops on how to speak better? And this is again a problem of time. We need to build this now. We need to educate the people when it's not a crisis to then actually have the capacity in the moment we need it most. And for that we need an infrastructure where this is also rewarded in a way of part of being and working in the health system, that this is not just about delivering treatments, but about interactions with humans. And one aspect of rewarding this more can be that this is part of a curriculum for future medical doctors to actually work way more on empathetic interactions with people rather than only focusing on the medical aspect of it, because it's not only that. They are not just engineers, and most of them acquire that then during their jobs, but that's not fair to just throw someone out there and say, learn it, and maybe in 10 years you're good at it, because that comes at a price, right? So I think we really need to look more into the future and build a bigger vision of what we want to achieve, and there is no short answer to how to build trust. So we need to change curricula, we need to change the way we think about medicine, more about also a person-centered approach rather than just talking about treatments.
If I can jump in, I think we already have some of those structures in place. They just could be utilized better. For example, physicians do and nurses do continuing medical education throughout their career, and they need to do it, and they need to get credits in order to keep their licenses. So you could have curriculum around building techniques for building trust, and you could focus on specific issues, let's say vaccination issues.
Great. And actually, I think education is one big way to do it, but I'm going to take the opportunity. So I'm going to come to all three of you in turn with this question. So I'll come to Adam and then Maya and then Philipp eventually. But it's a question, a bit of a combination from Gabrielle and Alison. And it's more or less along the lines of that it seems our political will to build trust and to maybe make these changes to our educational systems, to have these trust building initiatives, they're really only coming in times of emergency. So we're a little bit too little, too late. We don't have them built in advance. And I know, Adam, even through some of the work you presented, it seemed like outbreaks were kind of the catalyst for being able to build trust. So each of you, just briefly, what's something you could consider for building this trust outside of the scope of a health emergency?
Yeah, thanks. I think you're completely on the money to say that the biggest engagement we all get around the table when there's an emergency and there's a response needed. I think where we have demonstrated that value is that following that we have a reflection of an outbreak, like say mpox, but since then we have maintained contact. And we would actually have regular kind of working group meetings where the same people would come back around the table. It may not be specifically about mpox, but let's look into the future to what else might be coming down the road, or the next thing that our community has identified as a deficit from previously. So I think maintaining those relationships and not, hanging up the phone until the next time the buzzer goes off for the next outbreak.
And Maya, what do you think in 30 seconds or a minute?
I wanted to support what Adam said, keeping the contacts going even during quiet times, and also and one way to do that is bringing health to the community. So having now, at least in Canada, we don't have money for this anymore, but we used to offer public health through the schools, and you can have visits at places of worship, community centers, bars and clubs, if that's appropriate. That's how you keep people engaged when they see you around and you're available, not just during the crisis, but during good times too.
And Philip, I'll give you the last word on this.
Thank you. Yeah, I think that in general, we said a lot about that we need to implement these measures now and not think about a crisis mode, but we actually, for inoculation interventions, we need to know now what the people think. For healthcare interventions, we need to build and train people now, but we can also consider science not only as a way to build new interventions, but also as an intervention in itself. What people want and what people want from people that they then call trustworthy people is that they are open to their opinions. By measuring what people think, by doing also qualitative work on asking them what they think, we already contribute to that. We contribute to showing that we care. And science can be an intervention for trust itself.
And I appreciate all three of you being here to share your perspectives. I think different perspectives, but incredibly complementary. And I really appreciated the discussion we had and allowing me to challenge you with some challenging questions. So thank you to all three of you. And before I wrap up, my team in the background is going to put on the screen a QR code. And I would like you to just scan that briefly, hold it open on your phone, because before you go, we would like to just give you a final closing remark about the ECDC Lighthouse. And I will tease before I pass it over to John that because this discussion is clearly interesting, we have a lot more to say. The first discussion topic will be on the ECDC Lighthouse platform, we'll be continuing this discussion from today. So I'd encourage you to join us there. And with that, another thank you to our speakers again, and I'm going to pass it to John for a final word.
Thank you, Zach. Thank you, Adam. Thank you, Philip. Thank you, Maya. Fantastic presentations, really rich discussion, and many, many wise words. It's super to hear it all together. I feel really inspired by all that you've put with us. And I think that so many kind of nuggets have come into my mind, but I think one of the things that really comes into my, if I'm going to review it in its essence, is nothing about us without us. I think that's a beautiful way to put it. If we're trying to build trust with the community, we have to understand what the community is all about, and we have to work with the community. So I think let's take that as a really great message home from this webinar. So thank you so much, you three, for being with us. Thank you to all the participants. We had up to about 170 people, which is fantastic. And I hope you have managed to enjoy as much as I have and learn all the good things that we've come out of this. If I could ask, please, Delia, to put up that slide regarding the future of where we're coming very shortly, because we are going to launch this Lighthouse. It's called the Lighthouse, as I said at the beginning, formally our community of practice on Wednesday, the 20th of November, in just under 2 weeks. If you've already signed up, then you're going to get a message to join us. But if you haven't, please go ahead and scan this QR code, and it'll take you to the registration, and you can then register your interest, and we will then bring you into the community in due course. So that is something which I think is really, really important, and we want to have as many people with us as possible. We're going to have more webinars. We're going to have another one next month, and you'll be hearing about that through the community, through the Lighthouse, but also through social media, so stay tuned. And within the Lighthouse, there's going to be more activities that are going to be available to people. You will be able to enjoy networking activities, ask the expert sessions, and all sorts of different things to activate discussion in various different areas, whether it's about vaccination, whether it's about AMR, whether it's about HIV and TB, or whether it's about outbreak response, all sorts of areas where social and behavioral sciences in its many guises plays a role. So please do go ahead and register your interest. And I would like to, with that, to thank you. Thank you for your time. Thanks to everybody, and I wish you a very lovely weekend. Bye-bye.